Good morning. My name is Joe Carcillo, and on behalf of my colleague Suchit Ranjit, we'd like to welcome you this morning, the brave and the hardy who come out at 8 o'clock in the morning. We're going to start the session by going over the guidelines that are about to come out of how you manage hemodynamic support of children with sepsis after the first hour. And then Dr. Ranjit is going to give a perspective about how one can do that in the developing country. And she's done a very important study in dengue and in bacterial sepsis and septic shock looking at these issues. So we look forward to this. Remember, the guidelines are stepwise management of hemodynamic support in infants and children. So if in your first hour with fluids and a peripheral inotrope or fluids and a central inotrope, the child is no longer in shock, then you don't go on to what we're about to talk about. So in the first hour, you use capillary refill of less than 2 seconds, normalization of heart rate, and normalization of blood pressure. So if you've attained those goals in the first hour with resuscitation, then what we're about to talk about is not important. But if you have not attained those goals, then we go on to a second level of goals, which is a central venous saturation greater than 70%. And if that's not successful in reversing shock, then also a cardiac index between 3.3 to 6.0. So if you have catecholamine-resistant shock, meaning the child who is cold is still in shock despite being on low-dose epinephrine, or the child who is warm remains in shock despite norepinephrine, then we call this catecholamine-resistant shock, and we recommend beginning hydrocortisone if you think the child's at risk of adrenal insufficiency. That population would include patients with Waterhouse-Friderichsen, patients who have been on steroids in the past, which in our hospital at least is 50% of patients who develop shock. They're either cancer patients or Crohn's disease patients or various other forms where physicians give steroids as part of their chronic management. We do not recommend giving it for what's called relative adrenal insufficiency. In the adult guidelines, they suggest that all patients get hydrocortisone if they're not responding to epinephrine or norepinephrine. We do not recommend that. We recommend using hydrocortisone only in those who fit that category of risk of adrenal insufficiency. Now, you can test, if you wish, the adrenal axis as well. And if you do a basal cortisol and it's less than 5, that is a definition of adrenal insufficiency. But if it's less than 18 micrograms per deciliter, or if you multiply that times 17, if you use micromoles, then that can also be considered adrenal insufficiency, because in the presence of volume-loaded shock requiring epinephrine or norepinephrine, you should have a cortisol level above 18, or 18 times 17 is approximately 400. If you're not responding at this time, then definitely you need a central line access, and your new goals are to maintain a mean arterial pressure minus central venous pressure that's normal for age, and those normals are in the guidelines. And they may not be normals per se, but they're the blood pressure goals below which we have increased mortality. So in a baby, for example, it's 70 over 50, or it's a mean of 55, and so on. In addition, the SCVO2 of 70%. Now, SCVO2 means that it doesn't have to be the SVCO2, so it can be from below. Many people start their central lines from below, but remember that when you start your central line from below, you have to bring it up to the atrium to get a venous saturation. If you're simply measuring the saturation of a short line from the femoral, then you're only measuring how much oxygen is extracted by the leg. You're not measuring how much is extracted by the organs. And nobody knows the normal venous saturation of the leg, so we can't really suggest that to you. But we do know the normal venous saturation of the IVC or the SVC at the level of the heart is 75%. Okay. You can then categorize your patients in one of three categories: cold shock with normal blood pressure, cold shock with low blood pressure, or warm shock with low blood pressure. Cold shock with normal blood pressure, your primary goal is to titrate your epinephrine between 0.05 to 0.3. After you get up to 0.3 mics per kilo per minute, you'll find that you get vasoconstriction and poorer cardiac output, not better. And your goals are to have your SCVO2 greater than 70%. If it's less than 70%, then you check your hemoglobin, and if your hemoglobin is less than 10, then you give blood. When you resuscitate a child with crystalloid or with albumin, if you give them 60 mLs per kilo, the total blood volume of the baby is 60 mLs per kilo, so you can induce a severe anemia. And that anemia is fine if the patient's venous saturation is normal, but if the venous saturation is low, then we recommend giving PACC cells or blood, depending on your country, to get a hemoglobin over 10. Now, in addition, if the patient is still cold and normal blood pressure with a normal SCVO2 despite being on low-dose epinephrine, then you should add a vasodilator. We recommend either the nitrosa vasodilators, which are nitroprusside or nitroglycerin, or the type 3 phosphodiesterase inhibitors. These include milrinone, amrinone, which used to be amrinone, or enoxamone. When you use these agents, which are vasodilators, you'll commonly see the blood pressure go down. Do not be concerned about that. Just give more volume. Okay? And then we are excited about a new medicine. There's not much on it, but it has been reported to be effective as a rescue medicine called levosimendan. In our country, we do not have levosimendan, but for those of you who do have it, you can certainly consider it in a child who continues to be in shock despite your therapies. Levosimendan is a type 3 phosphodiesterase inhibitor, but it also improves or sensitizes calcium binding to the actin tropomyosin complex, which is the primary defect of cardiac abnormality in sepsis, and it also reverses the potassium channel abnormalities of the vasculature. So it will perhaps be ideal. In the studies where it's been used in sepsis thus far have been just case series and case reports. So that's why we minimize it to a last resort at this time until there's more information. Another category of patient is cold shock with low blood pressure. Again, it's a similar factor for the cold shock as you give epinephrine, but don't push your epinephrine up to high doses for blood pressure. Keep your epinephrine in the inotropic doses to help the heart. And if your blood pressure still remains unacceptably low, then add norepinephrine. And the reason is this: epinephrine will give you an inotropic effect, but as you get up to high doses of epinephrine, you increase myocardial oxygen demand in the heart quite a bit. So you get high lactate levels, and although the patient may tolerate it, it makes much more sense to use norepinephrine if you have a low diastolic blood pressure problem. So the combination of epinephrine and norepinephrine, or epinephrine, norepinephrine plus dobutamine should be used to get your blood pressure to be normal and your SCVO2 greater than 70%. Now again, if you still have a problem with the patient having low cardiac output, low venous saturation, then you should consider adding milrinone, enoxamone, or levosimendan as, again, a rescue. And the thing to remember about phosphodiesterase inhibitors is when you add them to norepinephrine, they will not drop your blood pressure. So I'll just say that again. If you add a type 3 phosphodiesterase inhibitor to norepinephrine, it will not drop your blood pressure. And the reason is that norepinephrine does not have a beta-2 receptor effect. It has a alpha and a beta-1. So when you use the type 3 phosphodiesterase inhibitors, you'll increase the inotropy without causing increased vasodilation. This is different than in patients on epinephrine. If you're only on epinephrine, epinephrine is a beta-1 and beta-2 agent. So if you block the breakdown of cyclic AMP, then you get better inotropy because you get more cyclic AMP in the heart, but you also get better vasodilation peripherally because you're also blocking the breakdown of cyclic AMP from the beta-2 receptors in the vasculature. So that's why you can add the type 3 phosphodiesterase inhibitors without worrying about hypotension in this group is because you're on norepinephrine. And indeed, the treatment for type 3 phosphodiesterase inhibitor toxicity, milrinone toxicity, etc., is to just give norepinephrine. Now, this group of patients makes up the group of patients who regularly die of septic shock in the adult population, but they rarely cause death in the child population. And it would be quite remarkable to find a neonate where this occurs. And this is the warm shock with low blood pressure. Much of the warm shock, low blood pressure that you see is an adrenal insufficiency. And when you treat adrenal insufficiency, this is a vanishingly small disease, except for perhaps a couple groups of patients. Those are patients with liver failure and perhaps patients who have a high degree of enteric dysentery. I say that perhaps because it looks like in the Mexican database, although they thought the majority of their patients were this, they're not. It's only about a third are in this category. So in this population, you titrate the norepinephrine to higher doses. But as I showed you yesterday in a patient, as you go up in your norepinephrine, your SCVO2 may go down as you increase the afterload with your alpha agent. And keep that in mind. If you see that happening, then you have to add an inotrope such as dobutamine or milrinone again. If norepinephrine is not successful in bringing your blood pressure up, then you can consider and use vasopressin, terlipressin, or angiotensin. No study has shown a survival advantage to this in a randomized controlled trial, but we certainly all agree that if someone's in refractory shock, that the addition of vasopressin or terlipressin or angiotensin to rescue them at that time is fine, but we only recommend its use if you're going to measure some measure of venous saturation or cardiac output, because you'll commonly see that when you use these agents, which are not inotropes, that you'll have a drop in your venous sats less than 70%. And if you do, but you've restored your blood pressure, that's quite okay. But remember, you now need to add an inotrope such as dobutamine or low-dose epinephrine. Now, this last part is really only available to very technologically gifted ICUs, so we really only expect this to be in the developed world. So we don't expect this for the developing countries. And what I want you to tell you is this really only represents about 5 to 10% of the population. So if you are in a developing country, then we expect that your minimum mortality that you'll ever reach is between 5 to 10%. Because to save the other 5 to 10% of the children, you will need these higher levels of care. Okay, so this is great for everyone to listen to and learn about, but this is not our expectation for the developing world, but this is our expectation for the developed world. So for this part of Europe, the United States, Canada, Japan, and if I left anyone else out, Australia, New Zealand, but areas that we consider technologically abundant and fortunate. Okay, so if the patient still remains in shock, meaning their SCVO2 is low, then we want to rule out and correct pericardial effusion, pneumothorax, and we want to maintain our intra-abdominal pressures less than 12. This certainly can be attained in the developing country as well. The recommendation of the National and International Intra-Abdominal Compartment Syndrome Society, which is a wild society, but is dropped the number that used to be 15 down to 12. Now, the way you treat it, the way you measure it is by measuring bladder pressures. You take your Foley, fill it with water, and then just hook it up to your pressure manometer. That's how you can measure it. Or you can buy nicer equipment that's on display at the meeting. If the intra-abdominal pressure is greater than 12 but less than 30, you can use diuretic therapy. You can use neuromuscular blockers. If it remains elevated, however, then you should put in a drainage catheter into the belly for ascites. And certainly if it's greater than 30, then that's an emergency, and if a catheter should be placed for drainage. And if it's not an acidic problem, if it's just a very swollen bowel, then the surgeons should be consulted to open the belly. And since your Intra-Abdominal Compartment Syndrome Society is a surgical society, you just go to the web at iacs.com. You show it to your surgical colleague, and they'll be more than happy to do it because it's now considered their standard of care. Now, for the developed country, we expect you to have some way of measuring cardiac output. That way that you decide to do it is up to you. You can use a pulmonary artery catheter, a pico catheter, a Litco catheter, a femoral artery thermodilution catheter, or a Doppler ultrasound technique, or in the cyanine green. But the key is that if you remain in shock with venous saturation monitoring, we think you should measure cardiac output. Now, some centers will use non-invasive methods for cardiac output, and in that case, cardiac output goes to the beginning of the algorithm. But since there are so few centers that have access to this at this time, we can't place non-invasive measurement of cardiac output at the beginning of the algorithm. But that's certainly an option. And the goals here are cardiac index between 3.3 and 6. If shock continues to not be reversed at this point in time, then again, only in the developed countries, we recommend the use of extracorporeal therapies. There are two extracorporeal therapies to consider. First is continuous renal replacement therapy. This is recommended in any patient who is 10% fluid overloaded. So the way you measure that is, if a patient's 100 kilograms, then if you've given them 10 liters of fluid and they haven't removed that 10 liters of fluid, that's 10% overloaded. And so if you're 50 kilograms, it's 5 liters, and if you're 10 kilograms, it's 1 liter, and so on and so forth. And when you give 60 mLs per kilo, that would be not 10%, that would be 60%. So essentially, it's children where you're giving 100 mLs per kilo of fluid, and they're not having that fluid come off. Those patients should be placed in CRRT. Now, the group that's most commonly in need of this are the children with purpura fulminans, and because these children require FFP infusions to normalize their INR and reverse their coagulopathy, and you commonly require 100 mLs per kilo, and so those patients are the category that most commonly requires going on CRT early in their course, perhaps in the first 6 hours, while receiving FFP infusions. Now, less commonly, but still to be considered, is ECMO. The outcome in ECMO in pediatric septic shock is somewhere between 35 to 50%. The key to understand if you choose to go to ECMO is that mortality in ECMO in sepsis and septic shock is commonly related to asking the machine to give you too much flow for the size of the catheters, the raceway, and the oxygenator that you have in line. So you have a guide that will give you in terms of how much flow you can get from the machine. Commonly, you can only get a liter of flow, maybe 1,500, so it's just an assist device. It's not a full flow device. So you continue to use epinephrine and milrinone and nitride to get a better cardiac output while using that machine. And if you see hemolysis, then you need to back off on your flows. Now, the neonatal guidelines are similar. Again, catecholamine-resistant shock is maintenance of a perfusion pressure and SCVO2, but also in the neonates, and there's a new way, particularly in premature babies, of measuring systemic flow, which is the superior vena cava flow, and the goal there is more than 40 mLs per kilo per minute. This is an advantage in babies who have PDAs, because if you're trying to measure cardiac output in a patient with PDA, some of it's going backwards, some of it's going forwards. But if instead you measure how much blood is returning from the brain back to the body, you get a better idea of perfusion. Other people are using things such as NIRS or neuroscopy, but they have not provided us with a goal at this time, so they're not in the recommendations. So the key to understand is we're going for recommendations of goal-directed therapy. Cold shock in the children who are newborns, you have to make a diagnosis of you have LV failure or RV failure. And if it's LV failure, it's the same exact recommendations as in children, with the exception that you maintain your hemoglobin above 12, not above 10. But nitrous vasodilators and milrinone are fine in the presence of low-dose epinephrine. Cold shock with low blood pressure and evidence of RV dysfunction or persistent pulmonary hypertension, the new recommendations are that you not only use inhaled nitric oxide, But if that's ineffective, you can add a type 3 phosphodiesterase inhibitor, particularly milrinone, which is more selective for the pulmonary vasculature. You can also consider inhaled Ileprost or prostacyclin and intravenous adenosine. And this group is quite small. However, it does exist, and that's the group with warm shock and low blood pressure. Usually this exists in patients who have gotten too much milrinone, but nevertheless, you can use, as in the children, norepinephrine. And if you go to vasopressin or terlipressin, remember, it must be done in the presence of monitoring of venous saturation or SVCO flow or cardiac index so that you don't inadvertently reduce cardiac output. For refractory shock, it's again rule out and correct pericardial effusions or pneumothorax. And we recommend using hydrocortisone if the patient has adrenal insufficiency, again with the test that we talked about. We recommend triiodothyronine if the patient's hypothyroid. We recommend beginning pentoxifylline if you're a very low birth weight baby. And if the child has a PDA and it's hemodynamically significant, we recommend consideration with the surgeon as to whether or not ligation is indicated. If shock is not reversed, we recommend, not just consideration, but recommend ECMO for the neonate. Again, when you are on ECMO with a neonate with sepsis, do not go to high flows. The maximum flow that you want to use on your ECMO circuit is 110 mLs per kilo per minute to minimize hemolysis.